Block simulation 26. Same process, fresh set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Which structure has the fastest conduction velocity and which has the slowest, creating a critical delay? A physiologist studies the conduction system of the heart and the speed of impulse propagation through each part. Read the command, fastest and slowest conduction. Purkinje fastest, AV node, slowest, critical delay. In the cardiac conduction system, the Purkinje fibers have the fastest conduction velocity. They rapidly distribute the impulse throughout the ventricular myocardium so the ventricles contract in a coordinated, near-simultaneous fashion. The AV node has the slowest conduction velocity. This slow AV nodal conduction is physiologically essential. It creates a delay between atrial and ventricular contraction, allowing the atria to finish emptying their blood into the ventricles, the atrial kick, before the ventricles contract. The correct answer is A. A memory aid for the order of conduction, SPEEE, fastest to slowest, is Park at ventricle house, atrium square, or simply Purkinje atrial muscle, ventricular muscle, AV node, slowest. The AV nodal delay is what produces the PR interval on the ECG and protects the ventricles from being driven too fast by atrial arrhythmias. The Purkinje fibers is fastest and the AV node as slowest, with its delay coordinating atrial, then ventricular contraction is the answer. What is the diagnosis and how is it managed pharmacologically? A premature infant has a continuous machinery-like murmur heard best at the left infraclavicular area with bounding pulses and a wide pulse pressure. Echo shows a persistent connection between the aorta and the pulmonary artery, a left to right shunt. The mother had a rubella infection during pregnancy. Read the command, diagnosis and pharmacologic management. Continuous machinery murmur, aorta pulmonary connection, rubella, PDA, endometricin closes, PGE1 keeps open. This is a patent ductus arteriosus, PDA. The ductus arteriosus is a fetal vessel connecting the aorta to the pulmonary artery. It normally closes shortly after birth. When it stays open, it creates a left-to-right shunt aorta to pulmonary artery, producing the classic continuous machinery-like murmur heard at the left infraclavicular region, with bounding pulses and a wide pulse pressure. It is more common in premature infants and is associated with congenital rubella. The correct answer is B. The pharmacology is the high yield point and depends on prostaglandins, which keep the ductus open. Indometacin and NSAID that inhibits prostaglandin synthesis is used to close a PDA. Conversely, prostaglandin E1 or Prostadil is given to keep the ductus open, which is life-saving in duct-dependent congenital heart lesions like transposition or critical coarctation to maintain blood flow until surgery. So, indomethacin poses, prostaglandin keeps open. The aorta to pulmonary continuous murmur, managed by indomethacin, close, or PGE1, keep open is patent ductus, or prostaglandin intetuous. Which statement about the TCA cycle is correct? A biochemistry student studies the citric acid, Krebs TCA cycle, which occurs in the mitochondrial matrix and generates reduced electron carriers. Read the command, which TCA statement is correct. Oxidizes acetyl-CoA, CO2, makes NADH-TFH2 plus GTP, rate-limiting E-isocitrate dehydrogenase. The citric acid TCAC Krebs cycle occurs in the mitochondrial matrix. It takes acetyl-CoA from carbohydrate, fat, and protein breakdown and oxidizes it fully to CO2, in the process generating reduced electron carriers, 3 NADH and 1 fat H2 per turn, plus 1 GTP substrate level phosphorylation. The NADH and FADH2 then feed the electron transport chain, where most ATP is actually produced. So the TCA cycle's main job is to supply electron carriers, not to make ATP directly. Its rate-limiting enzyme is isocytrate dehydrogenase. The correct answer is E. The regulation reflects the energy state. The cycle is activated by signals of LOW, energy high demand, ADP, low NADH-ATP ratio, and inhibited by HIC energy, ATP, NADH. The key conceptual point is that the TCA cycle itself makes little direct ATP, just GTP. Its real value is generating the NADH and FADH2 that drive oxidative phosphorylation in the electron transport chain. The mitochondrial oxidation of acetyl-CoA to CO2 producing NADH, FADH2, and GTP regulated at isocitrate dehydrogenase is the correct statement. What are the afferent and efferent limbs of the corneal blink reflex, and where is the lesion? An ophthalmologist tests a reflex. Lightly touching the cornea with a wisp of cotton causes both eyes to blink. In a patient with a lesion, touching the right cornea produces no blink in either eye, but touching the left cornea makes both eyes blink normally. Read the command. Afferent, efferent limbs and lesion location. Corneal reflex, afferent CNV, V1, efferent CN7, no blink touching right cornea, right CNV lesion. The corneal blink reflex has two limbs. The efferent sensory limb is cranial nerve 5. The trigeminal nerve, specifically its V1 ophthalmic division, which senses the corneal touch. This signal travels to the brainstem and drives BOT facial nerves. The efferent motor limb is cranial nerve 7, the facial nerve, which contracts the orbicularis oculi to blink both eyes, a consensual response. So touching one cornea normally makes both eyes blink. The correct answer is B. The lesion is localized by which side fails to sense versus fails to blink. Here, touching the right cornea produces no blink in either eye. The afferent signal is not getting in, which indicates a right CNV, afferent lesion. By contrast, if touching the left cornea made the left eye fail to blink but the right eye blink, that would indicate a left CN7 efferent problem. Since touching the left cornea gives a normal bilateral blink, both facial nerves work. Confirming the defect is the right trigeminal afferent. The afferent CNV corneal reflex with a right CNV lesion is the answer. What is the diagnosis, the embryologic origin, and the rule of twos? A 2-year-old boy presents with painless rectal bleeding melena hematochezia. A technetium 99 and pertechnate scan, Meckel scan, shows uptake in the right lower quadrant, indicating ectopic gastric mucosa. Read the command, diagnosis, origin, rule of twos. Toddler, painless GI bleed, ectopic gastric mucosa on Meckel scan, Meckel diverticulum. This is a Meckel diverticulum, the most common congenital anomaly of the GI tract. Its embryologic origin is a persistent vitelline omphalomycenteric duct which normally obliterates during development. It is a true diverticulum containing all layers of the bowel wall. It commonly contains ectopia tissue, most importantly ectopic gastric mucosa, which secretes ACIZ that ulcerates the adjacent ileal mucosa, causing painless lower GI bleeding melena or hematochezia, the classic presentation in a young child. The technetium 99 and pertechnate, Meckel scan, detects the ectopic gastric mucosa. The correct answer is E. The classic rule of twos summarizes it, occurs in about 2% of the population, located about 2 feet from the ileocecal valve, about 2 inches long, often presents by age 2, twice as common in males, and may contain 2 types of ectopic tissue, gastric and pancreatic. It can also cause intussusception, volvulus, or obstruction. The persistent vitelline duct diverticulum with ectopic acid secreting gastric mucosa causing painless bleeding following the rule of twos is Meckel diverticulum. Which statement about bile acids and the enterohepatic circulation is correct? A physiologist studies bile and the enterohepatic circulation. Bile acids are synthesized in the liver and recycled. Read the command. Which bile acid statement is correct? Made from cholesterol 7 alpha hydroxylase, emulsified fat, reabsorbed in terminal ileum, recycled. Bile acids are synthesized in the liver from cholesterol. The rate-limiting enzyme is cholesterol 7 A alpha HY hydroxylase. They are conjugated with glycine or taurine to make them more water-soluble, stored and concentrated in the gallbladder, and secreted into the duodenum after a meal. There, they emulsify dietary fats, forming micelles that allow lipase to act and fat-soluble vitamins to be absorbed. Crucially, about 95% of bile acids are then reabsorbed in the terminal ileum and returned via the portal vein to the liver to be reused, the enterohepatic circulation. The correct answer is C. This circulation explains several clinical points. Synthesizing bile acids from cholesterol is also the body's main route of cholesterol, disposal, which is why bile acid sequestrants cholesterol lower cholesterol. They bind bile acids, forcing the liver to use more cholesterol to make new ones. And because reabsorption happens in the terminal ileum disease or resection Crohn, surgery depletes the bile acid pool, causing fat malabsorption and gallstones. The cholesterol-derived bile acids that emulsify fat and are reabsorbed in the terminal ileum and recycled is the correct statement. Why does clozapine require monitoring, and how do atypical antipsychotics generally differ from typical agents? A patient with treatment-resistant schizophrenia is started on clozapine after other antipsychotics failed. He is enrolled in a mandatory blood count monitoring program. Read the command, why clozapine needs monitoring and how atypicals differ. Clozapine, agranulocytosis, CBC monitoring, atypicals fewer EPS, more metabolic effects. Clozapine is an atypical antipsychotic uniquely effective in treatment-resistant schizophrenia. The reason it requires mandatory regular blood count CBC monitoring is its risk of agranulocytosis, a dangerous, potentially fatal drop in neutrophils that leaves the patient vulnerable to severe infection. Monitoring catches falling counts early so the drug can be stopped. Clozapine also lowers the seizure threshold and can cause myocarditis. The correct answer is B. The general contrast between drug classes is the broader high-yield point. Atypical antipsychotics, clozapine, olanzapine, quetiapine, risperidone, etc. block both D2 dopamine and 5-HT2 serotonin receptors, and compared with the typical first-generation antipsychotics, they cause fewer extrapyramidal symptoms, less acute dystonia, Parkinsonism, tardive dyskinesia, but more metabolic side effects, weight gain, hyperglycemia, diabetes, and hyperglycemia, effects, weight gain, hyperglycemia, diabetes, and dyslipidemia. The clozapine agranulocytosis requiring CBC monitoring and atypicals fewer EPS but more metabolic effects is the answer. What is the diagnosis and the mechanism? A 16-year-old girl has heavy menstrual bleeding, frequent nosebleeds, and easy bruising mucocutaneous bleeding. Labs, prolonged bleeding time, normal platelet count, and a prolonged PTT with normal PT. The defect impairs platelet adhesion and stabilization of factor VIII. Ristocetin cofactor activity is reduced. Read the command, diagnosis, and mechanism. Mucocutaneous bleeding, prolonged bleeding time, prolonged PTT, abnormal ristocetin, von Willebrand disease. This is von Willebrand disease, the MOSD, common inherited bleeding disorder, usually autosomal dominant. The defect is a deficiency or dysfunction of von Willebrand factor V4, which has TW jobs. First, VWF mediates platelet adhesion to damaged endothelium. It bridges platelets to subendothelial collagen, so its deficiency impairs primary hemostasis, causing mucocutaneous bleeding, nosebleeds, heavy menses, easy bruising, gum bleeding, and a prolonged bleeding time with a normal platelet count. Second, VWF carries and stabilizes factor VIII in the blood, so VWF deficiency also lowers factor VIII, prolonging the PTT. The correct answer is D. The lab pattern is the key. A prolonged bleeding time platelet adhesion defect leads to prolonged PTT from low factor VIII with a normal platelet count. The ristocetin cofactor assay is abnormal because ristocetin normally triggers VWF-mediated platelet agglutination, which fails here. Contrast with hemophilia. A. Only PTT prolonged, deep bleeds, normal bleeding time, and ITP, low platelet count. Treat with desmopressin, releases VWF. The VWF deficiency impairing both platelet adhesion and factor VIII stabilization is von Willebrand disease. Which organism is responsible? A 22-year-old woman has mucopurulent cervicitis and pelvic pain. Her male partner has urethritis with a watery discharge but a negative gram stain. No visible organisms. The organism is an obligate intracellular bacterium that cannot make its own ATP. Some serotypes cause reactive arthritis, others cause trachoma blindness or lymphogranuloma venereum. Read the command. Which organism? Cervicitis, urethritis, negative gram stain, obligate intracellular, can't make ATP, trachoma reactive arthritis, chlamydia trachomatis. This is chlamydia trachomatis, the most common bacterial sexually transmitted infection. It is an obligate intracellular bacterium and an energy parasite. It cannot make its own ATP, so it must steal ATP from the host cell. Because it lacks a classic peptidoglycan cell wall and lives inside cells, it does not show up on routine gram stain. The partner's urethritis with a negative gram stain is the clue, non-gonococcal urethritis. It has a unique two-form life cycle, the infectious elementary body and the replicating reticulate body. The correct answer is E. The serotypes cause different diseases. DK cause genital infections, urethritis, cervicitis, PID, and neonatal conjunctivitis, and L1, as well as reactive arthritis, the triad of conjunctivitis, urethritis, and arthritis. Can't see, can't pee, can't climb a tree. Serotypes AC cause trachoma, a leading infectious cause of blindness, and L1, L3 cause lymphogranuloma venereum. Treat with azithromycin or doxycycline and co-treat for gonorrhea. The obligate intracellular, ATP-dependent, gram stain negative cause of urethritis, reactive arthritis, and trachoma is chlamydia trachomatis. Which set of cardiovascular and respiratory changes occurs in pregnancy? A physiologist studies the major maternal physiologic changes during normal pregnancy. Read the command, which changes occur in pregnancy. BOL, plasma volume, cardiac output. DOL, SVR, dilutional anemia. DOL, minute ventilation. DOL, respiratory alkalosis. Normal pregnancy produces major predictable physiologic adaptations. Cardiovascular, plasma volume, and cardiac output both increase. Cardiac output rises via increased heart rate and stroke volume to perfuse the placenta, while systemic vascular resistance decreases progesterone. Mediated vascular platelation in the second trimester before returning toward normal. Because plasma volume increases more than red cell mass, there is a dilutional, BHY-histologic anemia of pregnancy. Respiratory, tidal volume, and minute ventilation increase, progesterone driven, so the mother blows off more CO2, producing a mild compensated respiratory alkalosis. The correct answer is D. These adaptations explain common findings: the dilutional anemia. Check ferritin to distinguish true iron deficiency, the mid-pregnancy dip in blood pressure, increased GFR, and a sense of breathlessness with the mild respiratory alkalosis. Other changes include a hypercoagulable state, raising clot risk, and insulin resistance from human placental lactogen. The increased plasma volume and cardiac output, decreased SVR, dilutional anemia, and respiratory alkalosis are the normal physiologic changes of pregnancy. What is the diagnosis? A 55-year-old man presents with progressive weakness. Exam shows bulged upper motor neuron signs, spasticity, hyperreflexia, positive Babinski, and lower motor neuron signs, muscle atrophy, fasciculations, weakness, but no sensory loss and normal cognition, eye movements, and bowel bladder. There is degeneration of anterior horn cells and corticospinal tracts. Read the command, diagnosis. Combine UMN plus element signs, no sensory loss, anterior horn plus corticospinal degeneration, amyotrophic lateral sclerosis. This is amyotrophic lateral sclerosis, ALS, a progressive neurodegenerative disease of motor neurons. The defining feature is the combination of BOTH upper and lower motor neuron signs, UPPER motor neuron signs, spasticity, hyperreflexia, a positive Babinski from degeneration of the corticospinal tracts, and lower motor neuron signs, muscle atrophy, fasciculations, weakness from degeneration of the anterior horn cells. Critically, ALS spares sensation, cognition mostly, EYE movements, and bowel bladder function. It is purely a motor disorder. The correct answer is A. The mixed UMN and LMN picture without sensory involvement is the hallmark that distinguishes ALS from other conditions. Multiple sclerosis has sensory and other findings. Guillain-Barré is LMN with areflexia. Myasthenia is fatigable weakness. A subset of familial ALS is linked to mutations in the sodium 1 superoxide dismutase gene. There is no cure. Riluzole, an anti-glutamate agent, modestly prolongs survival. The combined upper and lower motor neuron degeneration-sparing sensation is amyotrophic lateral sclerosis. Which part of the spinal cord is degenerated, and what is this condition? A 50-year-old man with untreated syphilis for years develops a progressive sensory ataxia with a wide-based gait, lightning, shooting pains, loss of proprioception and vibration sense, a positive Romberg sign, and absent reflexes. His pupils constrict to accommodation but do not react to light. Argyll-Robertson pupils. Read the command. Which cord part degenerates in the condition? Tertiary syphilis, sensory ataxia, loss of proprioception vibration, Argyll-Robertson pupils, tabes, dorsalis, dorsal columns. This is tabes dorsalis, a form of tertiary neurosyphilis. The pathology is degeneration of the dorsal columns of the spinal cord and the dorsal sensory roots. The dorsal columns carry proprioception and vibration sense, so that degeneration causes loss of position and vibration sense, a sensory ataxia with a wide-based gait, a positive Romberg sign. The patient sways or falls with eyes closed, having lost proprioceptive input, absent deep tendon reflexes, and lightning shooting pains. The correct answer is C. The classic associated finding is the Ayard-G-Yale-Robertson, a pupil that constricts to accommodation near focus but does not react to light, the prostitute's pupil. It accommodates but does not react. Tabes dorsalis is one of the manifestations of untreated tertiary syphilis, along with general paresis and aortitis. The dorsal column degeneration causing sensory ataxia, loss of proprioception and vibration, and Argyll-Robertson pupils is tabes dorsalis. Treat with penicillin. What is the diagnosis and how does it differ from acute stress disorder? A 30-year-old combat veteran, 4 months after surviving an IED explosion, has recurrent intrusive nightmares and flashbacks of the event, avoids reminders, is hypervigilant with an exaggerated startle, has insomnia, and feels emotionally numb. Symptoms impair his work. Read the command. Diagnosis and difference from acute stress disorder. Trauma, re-experiencing avoidance, hyperarousal, 1 month. PTSD versus acute stress disorder, 1 month. This is post-traumatic stress disorder, PTSD. It develops after exposure to a traumatic event, actual or threatened death, serious injury, or violence, and is characterized by 4 symptom clusters: RE experiencing, intrusive memories, nightmares, flashbacks, avoidance of trauma reminders, negative alterations in mood and cognition, emotional numbing, detachment and hyperarousal, hypervigilance, a mood and cognition, emotional numbing, detachment and hyperarousal, hypervigilance, and characterized by 4 symptom clusters: RE experiencing, intrusive memories, experiencing intrusive memories, nightmares, flashbacks. These symptoms cause significant distress or functional impairment. The correct answer is A. The key distinction from acute stress disorder is duration. The two share essentially the same symptom picture after the trauma, but the timeline differs. A CUG stress disorder lasts from 3 days up to 1 month after the trauma, while PTSD is diagnosed when the symptoms persist for more than 1 month, as in this veteran at 4 months. Treatment includes trauma-focused psychotherapy, CBT, exposure, and SSRIs, SNRIs. The trauma-related re-experiencing, avoidance, and hyperarousal lasting more than 1 month is PTSD. Under a month would be acute stress disorder. Which diseases are these? And the enzyme defects. 2 boys have a mucopolysaccharidosis from a deficiency in degrading glycosaminoglycans. Patient A has corneal cording, coarse facial features, developmental delay, and hepatosplenomegaly, autosomal recessive. Patient B has similar features but no corneal clouding, has aggressive behavior, and the disease is X-linked. Read the command. Which diseases and enzymes? Hurler, iduronidase, AR, corneal clouding versus Hunter, iduronate, sulfatase, X-linked, no clouding, aggressive. These are the 2 classic mucopolysaccharidoses, in which glycosaminoglycans mucopolysaccharides accumulate. Patient care including Hurler syndrome. Patient is a deficiency of alpha-deuronidase, inherited autosomal recessive. It causes coarse facial features, gargoylism, developmental delay, hepatosplenomegaly, skeletal abnormalities, and, characteristically, corneal occluding. Hunter syndrome. Patient B is a deficiency of iduronate siduronidase, sulfatase, inherited X-linked recessive. It is generally and milder, notably lacks corneal clouding, and is associated with age-aggressive behavior. The correct answer is C. The high-yield discriminators. Hurler has corneal clouding and is autosomal recessive. Hunter has no corneal clouding. Hunters need clear vision to AMC. Is X-linked, so affects boys, is milder, and features aggressive behavior. Both accumulate heparon and dermaton sulfate. The 2 are a classic compare-contrast. The Hurler, alpha-L, iduronidase, corneal clouding, AR, versus Hunter, iduronate, sulfatase, no clouding, X-linked, aggressive, distinction is the answer. What is the syndrome, the inheritance, and the gene? A 40-year-old man presents with recurrent peptic ulcers, Zollinger-Ellison, kidney stones with hypercalcemia, and episodes of hypoglycemia. He is found to have tumors of the pituitary, the parathyroid glands, and the pancreas. His father and sister had similar problems. Read the command. Syndrome, inheritance, gene. Pituitary plus parathyroid plus pancreatic tumors, familial, MIN23Ps, autosomal dominant, menin gene. This is multiple endocrine neoplasia type 1, MEN1, also called Warmer syndrome. It is characterized by the 3 Ps. Pituitary adenomas, e.g., prolactinoma, parathyroid hyperplasia, causing the hypercalcemia and kidney stones, the most common manifestation, and pancreatic and GI endocrine tumors, such as gastronoma, causing the Zollinger, Ellison peptic ulcers, and iron zoonoma, causing the hypoglycemia. It is inherited in an autosomal dominant pattern, explaining the family history. The correct answer is C. The genetics MEME1 is caused by a mutation in the MENE gene, MEME1, a tumor suppressor on chromosome 11. Contrast, the MEN syndromes. MEN1 menin is the 3 Ps. Pituitary, parathyroid, pancreas, MEN2A, and MEN2B are caused by the RET proto-oncogene MEN11. MEN2A is medullary thyroid carcinoma, pheochromocytoma, and parathyroid. MEN2B is medullary thyroid carcinoma, pheochromocytoma, and mucosal neuromas. The pituitary, parathyroid, and pancreatic tumors inherited autosomal dominantly from a MEN2A tumors inherited autosomal dominantly from a menin mutation is MEN1. Which framework correctly classifies hyponatremia by volume status? A patient presents with hyponatremia, low serum sodium. The team evaluates the cause by first assessing the patient's volume status. Read the command. Which framework classifies hyponatremia by volume status? Hypovolemic, euvolemic, ESIAEH, hypervolemic, edematous. The approach to hyponatremia begins with assessing volume status, which sorts it into three categories. Hypovolumic hyponatremia. There is a deficit of both water and sodium from volume losses, vomiting and diarrhea, diuretics, or third spacing, with the kidney avidly retaining sodium, low urine sodium if the loss is external. Euvolemic hyponatremia, normal volume from SIADH, the classic cause, psychogenic polydipsia or hypothyroidism. Hypervolemic hyponatremia, there is excess total body water with edema, as in the edematous states of heart failure, cirrhosis, and nephrotic syndrome, where effective circulating volume is low and ADH is activated. The correct answer is E. This volume status framework guides treatment. Hypervolemic hyponatremia is treated with isotonic saline replace volume. Euvolemic SIAD is treated with FLUID restriction. Hypervolemic edematous is treated with sodium and water, restriction plus treating the underlying heart, liver, kidney disease, and diuretics. In all cases, correct sodium slowly to avoid osmotic demyelination. The classification of hyponatremia by volume status into hypovolemic, euvolemic, and hypervolemic categories is the correct framework. What is the sign code and what does the sudden eruption indicate? A 60-year-old man has the sudden appearance of many new, stuck-on appearing, waxy pigmented papules, seborrheic keratosis over his trunk over a few weeks. A workup reveals an underlying gastric adenocarcinoma. Read the command, name the sign, and what sudden eruption indicates. Sudden, mini seborrheic keratosis, plus gastric cancer. Lesser, Trilat sign, perineoplastic. This is the lesser Trilat sign. Seborrheic keratosis themselves are extremely common, benign, stuck-on, appearing waxy pigmented papules of older adults. Individually they have no sinister meaning, but the sudden eruption of multiple new seborrheic keratoses over a short period is the lesser Trilat sign, which can be a perineoplastic marker of an underlying internal malignancy, classically a GI adenocarcinoma, especially gastric cancer. The correct answer is D. So the key is the word sudden. An isolated or gradual seborrheic keratosis is benign, but an abrupt shower of many of them warrants a malignancy workup. This parallels acanthosis nigricans, the velvety flexural plaques, which, when it appears suddenly, is also a perineoplastic sign of GI adenocarcinoma. The two are related perineoplastic skin findings. The sudden eruption of multiple seborrheic keratoses as a perineoplastic marker of internal, often gastric malignancy, is the lesser Trilat sign. Which statement about thyroid pharmacology is correct? A patient with hypothyroidism is started on levothyroxine. Separately, a patient with hyperthyroidism, thyroid storm, is managed with multiple agents. Read the command. Which thyroid pharmacology statement is correct? Levothyroxine synthetic T4 for hypothyroid, TSH monitored, thyroid storm beta blockers plus thionamides, plus iodine. Levothyroxine is synthetic T4 thyroxine, a prohormone converted peripherally to the active T3. It is the standard treatment for hypothyroidism, with the dose titrated by monitoring TSH. The goal is to normalize TSH. For hyperthyroidism and thyroid storm, several drugs target different steps. Beta blockers propranolol control the adrenergic symptoms and, at high doses, block peripheral T4 to T3 conversion. Thionamide PDU and methimazole inhibit thyroid peroxidase to block hormone synthesis. Beta blocks peripheral conversion, and high-dose iodine acutely inhibits hormone relays via the Wolff-Kiefer conversion, and high-dose iodine acutely inhibits hormone relays via the Wolff-Kiefer effect. The correct answer is B. The paradoxical iodine point is high yield, although iodine is needed to make thyroid hormone. A sudden high dose transiently shuts down hormone synthesis and release, the Wolff-Chaikoff effect, which is exploited in thyroid storm and before thyroid surgery. The sequence in storm matters. Give the thionamide B4 iodine as used as substrate, the levothyroxine as T4 for hypothyroidism, and the beta blocker, thionamide, and iodine combination for thyroid storm is the correct statement. Which organism is responsible? The test and the treatment. A 6-year-old girl has intense perianal itching, worst at night, and is irritable and not sleeping well. Her mother applies clear tape to the perianal skin in the morning, and microscopy shows eggs that are flattened on one side. Read the command. Organism, test, treatment. Child, nocturnal perianal itching, tape test eggs flatten one side. Pinworm, enterobius, Scotch tape test, albendazole, apyrantel. This is Enterobius vermicularis, the pinworm, the most common helminth infection in the United States, especially in children. The hallmark symptom is intense perianal itching that is worst at night, because the adult female worm migrates out of the anus at night to lay her eggs on the perianal skin, causing the itching and disturbed sleep. The diagnosis is the Scotch THT test. Clear adhesive tape applied to the perianal area in the morning picks up the characteristic EGGS, which are flattened on one side, seen under the microscope. The correct answer is A. The treatment point is high yield because pinworm spreads easily by the fecal-oral route, scratching, then contaminated hands say, fomites. You treat the patient and the entire household to prevent reinfection with albendazole, mebendazole, or pyrantel pomade, and emphasize hand hygiene. The nocturnal perianal itching diagnosed by the Scotch tape test and treated with the whole household is Enterobius vermicularis, the pinworm. Which two signals are required? And what happens if only the first is delivered? An immunology student studies how a naive T cell becomes fully activated. Full activation requires TW signals. Read the command. Which two signals and what happens without signal 2? Signal 1, TCR. MHCR, MHC antigen. Signal 2, B7. CD28 co-stimulation. Signal 1 alone, ANEGI. Full activation of a naive T cell requires TW signals. Signal 1 is antigen recognition. The TCEL Rextor, with its associated CD3 complex, binds an antigenic peptide presented on an MHC molecule by an antigen-presenting cell, MHC class II for CD4 helper T cells, MHC class I for CD8. Signal 2 is co-stimulation. The B7 molecule, CD8086, on the antigen-presenting cell binds CD28 on the T cell. Both signals together fully activate the T cell to proliferate and differentiate. The correct answer is D. The consequence of an incomplete signal is the key tolerance concept. If a T cell receives signal 1, antigen recognition, without signal 2 co-stimulation, it does not activate. Instead, it becomes anergic, a state of functional unresponsiveness. This is an important peripheral tolerance mechanism that prevents T cells from attacking self-antigens that are presented without the co-stimulation that normally accompanies a real infection. The two signal requirements, TCR, MHC plus B7, CD28 co-stimulation with signal 1 alone causing anergy, is the answer. Block 26 is done. Let's review the 5 biggest traps from this block. Trap 1. A patent ductus arteriosus is closed with indomethacin, which lowers prostaglandins. Prostaglandin E1 keeps the ductus open, life-saving in duct-dependent lesions. Prostaglandins keep it open. Trap 2. Von Willebrand disease prolongs both the bleeding time, impaired platelet adhesion, and the PTT low factor 8 with mucocutaneous bleeding and a normal platelet count. It is the most common inherited bleeding disorder. Trap 3. Amyotrophic lateral sclerosis combines upper and lower motor neuron signs with no sensory, cognitive, or eye movement involvement. The mixed motor picture without sensory loss is the signature. Trap 4. Hurler syndrome has corneal clouding and is autosomal recessive. Hunter syndrome lacks corneal clouding, is X-linked, and features aggressive behavior. The corneal clouding and inheritance separate them. Trap 5, full T-cell activation requires signal 1, antigen on MHC binding the T-cell receptor, plus signal 2, B7 co-stimulation of CD28. Signal 1 without co-stimulation causes anergy, a tolerance mechanism. 26 blocks, 520 questions. Train process, not memorization. StepLogic, learn how to think, not memorize.